Good morning, everyone. Great. Thank you for being here today. Thank you, Dr. Stein, for being here and for kickstart this session today. This is our annual educational event where we try to provide as much update as we can about what we are doing along with the educational activities. So Jenna just provided updates on some of the stewardship initiative. I'll take some time to provide information about the rest of the things that we are doing in the HAIAR program and where we want to kind of see ourselves going. And I think you will find some of the information very useful and very informative. So let's move forward. I have received funding from Merck for a research study, but it's not relevant to this presentation. These are the objectives. Most of you already know how the HAIAR program is set up in Nebraska, but for those who may not be completely aware or you're new to the area, our model is a state and academia partnership model, where the State Health Department has a partnership with UNMC and Nebraska Medicine to provide subject matter expertise so that we can then provide that subject matter expertise to all of you across the state. The state team monitors, do all the surveillance activities, initial outbreak response, or assist facilities with data reporting and validations. However, the academic partners are doing outreach, voluntary assessments of the programs, education guidelines development, and they do help with outbreaks and outbreak responses too, as needed with the state. This is our entire team. They are here. Feel free to get in touch with them, get to know them. I'm not going to go into all of the details. The blue kind of boxes represent those of our team members who have DHHS credentials, and the ones in the kind of orange boxes are the team members that are primarily working on the ICAP and the ASAP initiative. So when you see them, you kind of figure that out, but it's all kind of the whole big team. Recently, we have also onboarded many of the local health department. Actually, all of the local health department now have HAIAR liaison. They are working with us, the state health department, to help you guys across the state. So if you don't know who is the HAIAR liaison at the local health department for your jurisdiction, reach out to us or just see us in the, I think Caitlin is around on the booth today in the break. You can find out from her too. These are the different areas we focus on: healthcare-associated infections, multi-drug resistant organisms, outbreak prevention and containment. The ICAP team does the ICARs. The ASAP teams, are involved in antimicrobial stewardship assessments and response. They're also working on the antibiotic use surveillance that you just saw. And then, we are working on education. Today is the example of that. And we are also have a program called Project First Line, which focuses on frontline staff education. So your nurses, CNAs, physicians, whoever else is working on the front line, we are working to get them educated too on infection prevention and control. So now going into the data for healthcare-associated infections, how are we doing nationally? So if you see the comparison, this is the most recent comparison, the most latest comparison we have, because CDC is always a little behind on their reports. So when they have compiled the report, Nebraska is doing pretty well in many of the areas, as you can see, in healthcare-associated infections. The 4 areas that I've highlighted here that we were higher, we have higher than expected infection, and we were higher than the rest of the nation, were the ventilator-associated events, surgical site infection after colon surgeries, catheter-associated urinary tract infection, and C. difficile infection. Those were the four areas that we saw ourselves in 2023 being up than the nation, correct? So how did we do in that previous year from 22 to 23 in those four areas? So if you see in those four areas, in two of them, catheter-associated urinary tract infection and ventilator-associated events, even though we were higher than the national average, we were coming down from 2022 to 2023. The two areas where we actually did not go down, or maybe even go a little bit up, were the surgical site infections after colon surgeries and the C. difficile infection. So those were the areas that we were kind of monitoring. And as you know, when you look at it overall in the big picture, Nebraska was ranking 43rd in the surgical site infections after colon surgeries, and we were also in the top 10 highest C. difficile infection. Looking into C. difficile infection, we were also in the highest case rates in the nation. So with that information, we have been working on it for the last few years. We have a work group called Surgical Site Infection Subcommittee for HAIAR Advisory Council, who is working on getting the surgical site infections down after colon surgery. And many of you are actually, or some of you are actually in that subcommittee. Many of you have received surveys from us, on the practices and things like that. I'm happy to say that, even though we were higher in 2023, if you look at the most recent data, after surgeries, after hysterectomy, infection after colon have gone down since 2023. We saw those bumps in there. I don't know whether we don't have the pointers, correct? Let's see if I can point. That's not okay, fine. But we went up in 2023 and then, went down in 2024, still coming down in 2025. So that's all, I think, good. The only thing about 2025 is that we still have the year to go, half a year to go, plus there can be delayed reporting in there. So we don't 100% know that it is going to remain like that, but I think we're feeling comfortable in those areas. If we look into the C. difficile infection, again on the bottom there, in 2023, you were seeing we were starting to go up a little, and that's where we got up above the nation kind of thing. But then from there onwards till now, we're starting to go down again. So I think we're probably doing much better now in C. difficile infection than we were doing 2 years ago. So that gives us a little bit comfort. We'll continue to keep monitoring that. We'll continue to work on the antimicrobial stewardship programs and collaboratives, because that will help the C. difficile infections too. I was mentioning last year about our ventilator-associated events number were kind of going back up a little, but then we are starting to see that has been coming down again. So that's a good news there. If the only area where I think I have some concern, or the team has some concern here, is after surgeries for hip and knees. You can see that after hip in 2023, we were in the top 10 highest infection rates after hip surgeries. And for the knee, we were kind of in the middle of the pack. But if you look at overall kind of graph, you can see that for the most part, we have been on the top part of the one, which is not a good thing to see. Now with the hip surgical site infections, it appears that we were about starting to come down. This year data, we still have to take it with a grain of salt, because there can be delayed reporting on that, and we may see some numbers popping up. This is an area where we want to keep, the 2.0 is like double what are we expecting the infection to be. So that is not necessarily good last year. We hope that it will remain like this year, but we need to kind of keep a watch on that. So we will be working with our subcommittee on surgical site infections to maybe shift our focus from colon and hysterectomy surgeries to now, the hip and knee surgeries, especially if we continue to do better in those two areas previously. Okay, shifting gears to the multi-drug resistant organisms now. Thank you. Um, Thank you very much. Okay. So with the multi-drug resistant organism, as some of you already know, or maybe most of you already know, that we get all the positive cultures for most of the common microorganisms. Whether this is susceptible organism or resistant organism, doesn't matter. If it's E. coli, we get electronically, we get reported to the state. Um, uh, if it's Enterobacter, if it's Citrobacter, if it's Klebsiella, if it's Pseudomonas, we are getting all of those results, correct? So we are able to see, what our volume looks like in terms of positive test results for those organisms, and what percentage of those organisms are resistant to different antibiotics. So if you look at this, of all the Enterobacteriales, ceftriaxone resistance, which is a marker of ESBL organisms, have been slightly gradually going up over the years from 6.4% to this year 7.7%, meaning in some of your jurisdictions, um, I have seen that in some local health jurisdiction, it has gone over 10%. In some other jurisdiction, it's around 5%. For some of your facilities, it might be becoming endemic, and for some other facilities, it's still probably a little rare. So that's why it's in our tier 3 MDRO category. The tier 4 MDRO category is all endemic. MRSA, VRE, they're all in tier 4. Tier 2 is the rare organisms, the CPCRE, the C. auris. Tier 3 is where it's a transitionary period. So for some of you, it might be still rare. You might still want to kind of do due diligence on those, on the infection prevention aspect of the. For some of the other facilities, it might be endemic. But for carbapenem-resistant Enterobacteriales, they're still rare. So still about one. Well, I think real is a relative term, but there's still 1%, around 1.2% that has been stable over a period of years. Where we have starting to see, hold on. I'll hold on the third. Let's talk about Pseudomonas also. So Pseudomonas, I think we are seeing that about 90% of our Pseudomonas cases are not resistant to carbapenem. They are carbapenem susceptible. The 10% that are carbapenem resistant are either susceptible to cefepime or ceftazidime. There's only 1% of that is resistant to carbapenem and resistant to cefepime and ceftazidime. So those are the organisms, those are the Pseudomonas, those are the Pseudomonas cases where we are checking for carbapenemase production. And I can tell you that entire last year, we only found one carbapenemase producing Pseudomonas aeruginosa in the entire year. So we're doing great, on that aspect there. But where we do have concern is carbapenemase producing Enterobacteriales. Carbapenemase producing CREs. That's where we have the concern. If you can see, over the years, it has been, numbers have been going up. We doubled in the last year. If you can see on the specific genes, the KPC organisms that KPC genes that has kind of tripled in the last year. Or quadruple. So I think out of the KPCs that we have seen 12 KPC2, 2 KPC3, 4 KPC4s, 1 KPC6. The KPC4 are actually very rare. So I think these are the areas where we are focused on now, and working with some of the facilities where we're seeing increasing cases to figure out the underlying reasons for that and work on that. Moving on to C. auris, with the C. auris cases, we, as you know, we didn't have C. auris cases until 2023. We have one case in 2020, and then one case late in 2023. Both of those cases were imported cases, meaning that they had an exposure somewhere else, they were colonized somewhere else, they just came after that to Nebraska. However, in 2024, last year, we have our first transmission detected in Nebraska, and we sent out this hound last year. Basically, it was a case that have received healthcare outside of Nebraska, in another state, came to Nebraska, got into one of our healthcare facilities where they were tested positive. We started a response. In that response, we did not actually see any transmission in the first couple of months. So that we were doing good at that point. We thought we have it under good control. But then in 2024, about 3 months after that, we did identify another case which on whole genome sequencing match with the first case. So now we have a transmission there. From there onwards, there were about 109 exposures. We contact trace those exposures, start to do colonization screening to identify if there is anybody else who became positive to that. We found 2 more cases, and then at that time, we started a process. It's also a unique process where we set up or flagged our health information exchange, which is Sync Health, health information exchange chart, flagged that for notification and to the public health if any time those patients who are considered exposed walks into a building. So if they have gone home and they couldn't be screened, we are not reaching out to their home because the transmission in the community setting is not necessarily documented that much. It's the healthcare setting where the transmission happens usually. So as soon as they come back for another visit or something else, to a healthcare facility, we get a notification. We notify the facilities, and some of you guys have heard from us that, hey, so and so have been exposed to CRS, is now admitted to your facility. Can you go ahead and do colonization screening on this patient, offer that patient the colonization screening? By that process, we were able to identify, we were able to kind of get to many of the exposed CRS cases. And then from there onward, by doing that, we were able to identify another case at another facility, because that person was discharged to that facility. So we worked with that other facilities also on their infection control and things like that. We followed them for about 6 months, did not see any single case again from that facility, from the facility B. So now we have facility A and a facility B, but we were able to contain that. All in all of these numbers are not actually correct. I should have updated that. This number is actually 204 of 423. It just didn't get updated. So 204 of 423 exposed people were actually screened. There were over 850, I think close to 875 screening tests that were done in this response over this period of time. But it was a successful response, and we were able to stop the transmission for Candida auris. However, I'll kind of skip through this, but this is the whole genome sequencing results that showed that these were all related cases. So it was one big cluster. And it was a great collaboration between the facility that had the cases, the health department, and those facilities who we were calling and were not involved in the outbreak, but were still cooperating to get those testing done so that we can make sure we identify all the cases and be able to contain this outbreak. So thank you very much for your participation in all of that. We were able to get it done really well. All in all, as you can see, 204 people were screened one time. Actually, 139 people of those 204 actually got screened 2 times, just to kind of make sure that we didn't miss a case on the first time. Plus, there were 490 testing on 411 individuals that were just done point prevalence screening, meaning that you are just going there and screening whether they are exposed or not, just to kind of make sure that we are not seeing random cases. So that was a great response and great collaboration with our facilities. And in 2025, unfortunately, there was another patient who received care in another state and came to Nebraska. And that started a whole new cluster, which is completely different from the previous cluster that we have successfully contained. We worked on it. We have 9 cases so far. Well, so far meaning when I was about to leave my office yesterday. over 800 colonization screening tests, 15 acute care hospitals, 57 long-term care facilities have already been involved in this process of the same process that I've described for 2024. Although this time around we are being selective on the notification because of whatever we learned from the last time around. However, as I said, as of yesterday, we were thinking that we have it contained, but now I will just say that you might be getting some more calls. So we'll talk about that later. Um, so uh, so so if you look into Candida auris, these are the drug-resistant yeast, and there are different clades of them. Not all Candida auris is the same. The Candida auris clade 1 is from South Asia, predominantly originated from South Asia. The clade 2 from East Asia, clade 3 from Africa, clade 4 South America, and clade 5 Iran. In Nebraska, the clades that we have seen are clade 1 and clade 3. Now, why is it important? Because clade 1 and clade 3 are the two most resistant clades. The clade 1 is about 97% of the time, as you can see, and same thing with the clade 3, 98% of the time, resistant to fluconazole. So high resistant pattern to fluconazole. You cannot use that. That's the most commonly used drug for that. And then clade 1 can also be resistant to amphotericin very frequently. So that's why we were concerned. Now, I can tell you this, that clade 1 is the only clade right now that caused these two big clusters, the 2024 one and 2025 one. Clade 3 was incidental finding. So while we were getting the response of clade 1 done, we incidentally found clade 3 cases because we were doing those much screening and point prevalence. So what it means is that we may have more, and we don't know where it originated. We know everything about clade 1, where the patient came from, which patient gave it to which patient. All of those information is available for clade 1. So we are able to, that's why we were able to kind of control that transmission. We don't know that dynamic for clade 3 cases. So there might be unknown clade 3 cases out in the community. So that's why we need to keep our guard up. We need to look for these things, and we need to identify and take precautions. And that is a chart that I've shared before. If you can see here, depending on what systems your lab are using for identification of Candida auris, there is a possibility of it getting misidentified to some other Candida species. If there is any concerns of misidentification, our public health lab colleagues do very well collaborate with all the labs across the state. Just send them the isolate for identification, and they can help. If your labs are not able to further, identify the species level for Candida positive specimens, then and it's growing from a sterile sample, send it to the public health lab. They can do the species identification for you guys. But we do want to know about these Candida, and we want to identify them so we can contain them. So what are some of the key observations and lessons learned from CPO and C. auris responses that we have? So first of all, we are still seeing hand hygiene and PPE compliance issues. There are still gaps existing in the environmental service staff education and training. The protocol will say sometime one thing, and the staff might be doing something else. So that training and education is still going to be very, very important. And with C. auris, you actually have to have a disinfectant that could work with C. auris. Not all disinfectant is going to be able to work with C. auris. There is also evidence now of environmental contamination or environmental reservoirs playing a role in transmission, both with C. auris and the carbapenemase producing CREs. We have seen situations where a patient who's positive for these organisms stayed in a room, left, 2 weeks later, 3 weeks later, somebody else came in the same room, stayed in there, and got the transmission because of that. Not that because they were both together at the same time. They were apart, sometimes weeks apart. or months apart. And there is a transmission event that we think is related to the environmental sources. So that's another thing that you keep in mind. We are working on some of these issues right now. Receiving healthcare outside of the state is a significant risk factor that we have seen. Both of our CRS clusters started after somebody got exposed outside, and we didn't have that person screened when that person came into our facilities. Whole genome sequencing has been doing a great job in helping us identify and contain our MDRO clusters. I think there will be a talk later on today on that, so looking forward to that. And then in transmission is not being seen when facilities are aware of colonization status of the patients and the residents. So if they are aware of the colonization status in general, it looks like when you are aware, you do the right thing. Most of the time you take the precaution and you are able to protect. So knowing is not actually a bad thing. Knowing is actually a good thing. So sometimes, I've seen this kind of thought process, like if you don't know, that's probably better. No, if you don't know, then you probably will have a bigger problem at your hand when you are going to identify it. If you know it, you can contain it earlier. So CDC have an MDRO prevention plan that they have published for public health to use and prevent transmission of multi-resistant organism in the state. They have 4 strategies, kind of doing education, improving infection control practices, detecting colonized individuals, what I'm talking about, and then facilitating communication. So we're doing good work in all of these areas. I think we can do better in the detect colonized individuals. I'm going to talk about it a little bit more. But this is the plan that we have in Nebraska based on the CDC recommendation. So our plan for the public health, to kind of talk to you about is do MDRO admission screening for high-risk patient, point prevalence screening for higher risk units or facilities, infection control assessment so that we can help you guide, infection control program improvements, educational programs focused on MDRO prevention efforts, and then, outreach to the facilities on admission for patients who are known to have the tier 2 MDROs. So that's where, when anytime known tier 2 organisms, so that's all these patients that have CRS now or the CPCRE, if they are discharged home, tomorrow, they go to a new facility for emergency, urgent care somewhere, we get an alert from the health information exchange that, hey, XYZ patient is now at this facility receiving care in the emergency department as of 5 minutes ago. And then we give you a call, and say, hey, are you aware? Many of the time, some of the time you are, some of the time you're not, that this patient is at your facility, and you may want to make sure that you have your system flagged for that. And you are receiving those calls, I'm guessing, because, on the weekends, I'm the one making those calls, so I know. And then the whole genome sequencing aspect of it, correct? But the area where I want to take a few more minutes and talk about is I don't think we are doing enough for MDRO admission screening and point prevalence screening. We're not doing enough, and I want to share at least some data that I feel like at least starting to tell us that it may help to do those things, and it may help increase, some outcomes. So in this particular study that was done in ICU patients, they were doing daily CPCR, daily screening for CRE, for carbapenem-resistant organisms or multi-resistant organism. So when they were doing the daily screening, what they found is that if you just rely on your clinical cultures results, what you will see is only 10% of the CPCRE patients. Okay, by just relying on the clinical cultures, you're only identifying 10% of the CPCRE patients. If you are doing admission and discharge screening, so on admission you do it, on discharge you do it. If you do that way, you will identify about 90% of CPCRE patients. And they also kind of do a sub-analysis where they have these 16 patients or 15 patients that acquired CRE after getting admitted to the facility, so within facility transmission. And if on discharge screening, they actually picked up 60% of those too. So if they were doing those admission and discharge screening, they were still able to pick a lot that would have otherwise been missed if just relying on the clinical culture. In this another study where they did admission screening and a point prevalence screening, meaning this was a cluster randomized non-blinded crossover study in which they were doing admission testing within 2 days of admission and then weekly surveillance testing on all the patients. When they did that, they did not see any decrease in the length of stay or any change in the outcome for cost or infections. But what they did notice, it was an underpowered study, but what they did notice is that there was a 50% decline in the acquisition of carbapenem-resistant gram-negative organism. So that definitely helped them by doing that. They did that. Another study where in the hospital, in a setting where carbapenem-resistant Acinetobacter was quite prevalent. So they were seeing increased incidence of carbapenem-resistant Acinetobacter. So they did this particular actually, they were just doing their intervention. So they tried to do contact precaution. It didn't help decrease the incidence. They did cohorting and dedicated staffing and auditing for hand hygiene, EVS practice. That didn't help much. Then they went into the phase 3 screening where they start to look for anybody from long-term care facilities or with prior hospitalization within the previous 6 months get admitted, they screen that person. And in the ICUs and the step-up units, they do it on admission, and every week after that, they start to see the decline then in their CRAB incidence rates after that. And hospital-acquired cases also went down in that study. This was another study which just looked into a review analysis, basically a systematic review that looked into different interventions to control carbapenem-resistant enterobacteriales. And they identified there were about 14 to 17, there were 17 facilities that tried, or 17 studies that tried active surveillance strategy to control. And in that active surveillance strategy, there were 14 of them. They did other things alongside the active surveillance strategy. And one of our colleagues from Pennsylvania, Dr. Graham Snyder, presented this data at HAIAR. So I kind of took his work and asked him permission to show here. And what he looked into is that, okay, how many of these studies were actually showing an improvement in the outcome? And he actually saw, that some of these studies, actually most of these studies were actually showing some improved outcomes in there. And we're starting to see the data now coming in for CRS2. And this particular study in New York, with admission screening, they saw the benefit of expanded screening for CRS when they start to see less hospital-acquired CRS cases after they implemented that screening in place. So I think what I was trying to say here is that we are starting to see the data that it actually can help to do the admission screening and point prevalence screening in the facilities. In Nebraska, we do the risk stratification of the facility. We call LTAC, VSNF, and hospitals that have transplant center or one units, we call them influential facilities because of the likelihood of prevalence of multi-drug resistant organisms in those facilities. The highly connected facilities are the ones that are receiving patients from those facilities, and then the rest of the facilities. The graphic here, graphic is the actual graphic of transfer network for Nebraska facilities. So it's have SNFs in there, it has acute care facilities in there, actually based on the 2021 data from CDC. If you ask me, I can tell you actually which facilities are most connected with you in terms of the transfer network. I might actually be able to share with you if you can reach out to me. I have to, well, might. I have to get permission from Dr. Stein before I do that. But I think I will be able to get that. And then after that, So once we identify those facilities, what our plan is that we are offering, assistance to the influential facilities in conducting targeted admission screening and or periodic point prevalence screening. Now, the best thing for facilities is to do it themselves. That's the best thing. Do it yourself. But in case you cannot, or you are in the transitioning period or whatsoever, we are here to step in as long as we have the funding. Okay. As long as the funding, we can definitely help with that process. If we run out of funding, then that's it. And for the highly connected facilities, we can still talk about it. I'm not sure that we will be able to give it to everybody to do that point prevalence screening. But if there is a good case for doing that or good case for doing admission screening, we'll be able to offer that too, free of cost, while the funding lasts. Now, for some reason, I cannot move to the next slide. And the next slide was basically the summary slide. So in general, we are, you can come there. In general, we are doing much better in healthcare-associated infections overall. Nebraska is doing great. There are some areas of concern. We will work on that. We can do better in the admission screening areas and things like that. So that's where we are here to help. Whole genome sequencing is another growing area. We will have a talk today, about that for hospitals to kind of look into that. With that, thank you very much for coming. Thank you for listening. Have a great rest of the day. I think we have couple of minutes if there are any questions.